Hello everyone and welcome to the live stream. My name's Kane Treble. It is good to have you all here and hopefully we're going to get ourselves ready for some more KFP preparation. For those that tuned into the little pre-show roll, you probably saw the old program up for CCE. I do apologise I hadn't got around to updating that yet, but tonight we're going to focus on KFP, get ourselves ready to sit the exam, and so without too much further ado, let's get into it. If you want to throw out who you are in the chat as well, just to introduce yourself, let me know what stage of your training you're at, and if there's any particular aspects of the KFP that you want extra kind of help or assistance with, and I'll try to get onto that. All right, so here we go. We have 73 days left until the 2024.1 or 2024.1 KFP exam. This is the first KFP I'm having in this session here. So for those who are new to this format or haven't seen this channel before, I do a little bit of training around KFP preparation and practice questions. We run through, tease apart some answers and try and work out ways we can make sure you pass your KFP when it is time. And of course, Jasmine, hey, how you going? Good to have you on board here tonight. Always happy to see some familiar faces. Now, of course, why should you listen to me? Very good question. My name's Kane Treble. I'm a GP registrar who's just finished their CCE exam just last week, which is why I didn't do the usual 12 weeks before session. I really did struggle with my KFP, and I wanted to make sure that there were as many resources as possible for people that were preparing themselves for this exam as well. So I'm based out of Mildura, Victoria, which is far northwest Victoria. It's about as far as you can go with it still being called Victoria. And again, I'd love to hear in the chat where you're from, so feel free to introduce yourselves. I'm a father of 2 little boys, a husband to a beautiful wife, and a massive nerd, which is why I thought I have the technical know-how to kind of put this together. I wanted to make sure we could actually keep going ahead with that. I sat the 2022 KFP exam and failed. In the F1 band, and for the life of me, I couldn't at the time figure out what I'd done wrong. I'd gone through one of the courses, thought I was prepared, and still didn't manage to pass. But it's okay. I then sat the 2023.1 KFP exam and failed again in the F1 band, and I was so frustrated by the lack of feedback, the lack of knowing what it was that I was doing wrong, that I spent a long time, a lot of money, and a lot of resources building up ways to work out, well, how can I pass? And I'm very happy to say that in the 2023.2, I managed to score a P3 passing with flying colours, and I wanted to make sure that other people that were in the same circumstance that I was in don't have to go through that same experience. That's why I'm putting all of this together myself. Now, again, I am a nerd. I'm putting through all of this in a structured course, stuff in writing, stuff in filming as we speak. So for those that might be interested, I thought I'd run through some of the things I'll be putting through in that. I'm not going to be charging. If you want to go through it for free, that's fine. I just want to get resources out there for people that need it. Tonight I wanted to spend a little bit of time talking about some of the traps that I know a lot of people do struggle with the KFP exam, and then go through some practice questions as well, and I'd love to get your responses back in the chat, and we can tease apart some of the answers and work out what could we do to maybe prime that to make sure that you get through the KFP with no troubles at all. Now, I've got a case thrown up onto here, and one of the first things that I think muck most people up is try to be specific and concise with your answers. So what we really want to do is make sure that we are getting straight to the point of our answer. He says, well, not getting straight to the point. I want you to imagine for a moment that you are one of the examiners marking this KFP exam. You've got a pile exam sitting at your desk, and your task is to mark a single question, a single case, out of 3 questions. And you have to do this 1,106 times. That's how many people sat the last KFP. Being specific and concise is important not only to display your fellow level knowledge, that is the point of the exam at the end of the day, to show that you know what it is you're supposed to be. Oh, let me just fix the audio, sorry. Yep. Hopefully that's a little bit better, let me know. You're showing that you have fellow level knowledge of the RACGP exams. So you will need to know that you can convey knowledge in a concise manner to get that point across. But you also want to make that examiner's life less than hell if you can. Remembering these are doctors marking the exam, which means that there's going to be that kind of interprofessional kind of courtesy and understanding of the language and words you're using. Your rough rule of thumb, though, being specific and concise, is I want you to use one answer, 1 mark, roughly, 1 line per answer. And as long as you can do that, I think you're going to do well. It can be really tempting to, in written exams, write out your answers in really long formats. But as much as you can, I want you to try and stick to almost bullet point format. Try and keep things really nice and short and sweet. Try to use detailed wording, but don't try and justify your responses unless it's specifically requested. You are asked what is the answer, you just need to specify what that answer is. Now, it also means avoid generalizations. And one of the things that mucks a lot of people up would be to say, for example, exercise. Now, that should be moderate intensity physical activity, 30 minutes per day, at least 5 days per week. And a great place to find information like that is in the handy handbook. Now, counter to that, you're better to sticking to what you know if you're not entirely sure. And one of the things that catches a lot of people out would be saying oral calcium supplements daily. And that's probably going to give you more marks than saying oral calcium supplements 1,000 milligrams daily in a postmenopausal woman, for example. Now, if you're needing to use a comma, the words and or if, you should probably reconsider if you're actually using 1 or 2 responses, and I generally recommend you try and simplify that down. And that kind of brings us into overcoding. Now, overcoding is a thing that I think mucks more people up than anything else. For those that aren't familiar with it, it's where you're giving multiple answers in your one response. The college not only frowns upon this, you actively lose marks for doing it. Now, if we take this particular case into consideration, if we were to say fecal occult blood test every 2 years from 40 to 90 years, colonoscopy every 5 years from 50 to 74, aspirin for at least 2.5 years between the age of 50 and 70. Or let's pop down here, fecal occult blood test, 2 years from age 40, comma, with colonoscopy. Now, if you were to write this with that comma there, if you were to write colonoscopy every 5 years from 50 to 74, 2 marks. Fantastic. IFOBT every 2 years, 40 to 49, 1 mark. It's less good in this situation, less good. That's great language, Kane. For those that haven't picked it yet, the reason why FOBT every 2 years from 40 to 49 wouldn't be as good for this case is the fact that we have a 55-year-old. So they're already over that age bracket. If you were to specify IFOBT every 2 years from 40 to 49 with colonoscopy every 5 years, you would actually start to lose marks. Now, overcoding, you lose marks for every bit of overcoding that you do, every bit of too much information. And I wanted to just highlight here, each instance of overcoding is 0.25% loss in marks from the total exam score. That doesn't sound like too much, but I want you to think about this looking at the 26 cases that make up the exam. So let's say overall, your score is 66%, and well done, you've done well. Overcoding just once for each case loses you a total of 6.5% from your total score overall, which would drop you down to 59.5. That could drop you down an entire band. But let's say you accidentally did that once for every response. That would actually drop you down significantly and would actually bring you down to 46.5%. This means from overcoding alone, a very simple mistake to make, you can go from a potentially P2 or P3 band all the way down to a fail. And I think this is probably something that catches more people out than we would necessarily like to admit. So again, a hint that things are overcoding is if you're using the words with, and, because, as, or a comma. And the rough rule of thumb I like to keep in mind is the mini mental phrase, no ifs, ands, or buts. If you're using any of those things, you probably need to trim it down. Now, for this response here, if we say did put this down and we wanted to try and simplify things, let's say we caught ourselves overcoding as we're going through again, how do we fix this up once we've caught ourselves doing it? And I want you to try and make sure you give yourself about 2 minutes per question so that you have the time to go back and revise your responses. For this situation, I would be, say, taking out that second response of aspirin, and I would be separating this out by just putting a 2 in front of that. Now, this breaks that into 2 clearly distinct different answers and would give you the maximum marks applicable for that question. likewise, let's talk about diversifying our responses. So, for this situation, we have what additional aspects of history would indicate a serious cause for symptoms. Well, let's go back a little bit. Different situation here. So we've got a photographer, 1 week of facial pain and nasal blockage. This began with a recent change in weather. She states she often gets this at this particular time of year, and for anyone that's spent more than a day in general practice probably knows where this is starting to head. No other significant medical history, no medications, non-smoker, but her boyfriend she lives with smokes. Always file those tidbits away. They're often going to come back later on. She doesn't drink alcohol, denies any recreational drugs. COVID's been definitively excluded. So far, the exams have really not wanted to ask any questions about COVID, so you can usually pretty safely exclude that from any kind of consideration. Vital signs as listed. What additional aspects of history would indicate a serious cause for her symptoms? List 4 additional aspects of history. If you wanted to throw some in the chat, let me know what you're thinking. But some examples that I came up with would be things like confused level of consciousness, diplopia, proptosis, and presence of periorbital edema. Now, these things, these answers are particularly good because it does cover multiple things at the same time. So, confused level of consciousness hints towards sepsis, the level of severity in particular. The diplopia hints more towards orbital lesions or lymphoma. The proptosis, bulging eyes, it's a common manifestation of fungal sinusitis, which, if it involves the orbits, a pretty big deal, so you want to get on top of that. And the presence of periorbital edema is a sign of orbital cellulitis. Now, again, remember that these are doctors marking the exams, and so they're going to see these things and they're going to understand what kind of things you're looking for as you're getting through those. Hopefully, that makes a bit of sense. Now, I'm keen, before each exam, we are going to be... just having a look through. Just getting messages about the audio. Glad to hear that's fixed it. Now, for those who would like to crack on and get to some practice questions coming up in just a minute, I'm keen to deal with some of the kind of traps or learning tips at the start of each presentation. There'll be one of these each Wednesday night at 8:30 once I get the kids to bed, if I get the kids to bed, and we'll run through some practice questions there. Sound good? Thumbs up? Excellent. Okay, so again, without further ado, let us bring up some of our practice questions. I'm going to, hopefully this works, trying some new automations. I'm going to put 2 minutes on the clock, and I want you to put your answers into the chat, and we'll spend a bit of time afterwards teasing apart and working out ways we can optimize your responses. All right, ready guys? Time starts now. All right. Good to see some answers coming in there. Now, I wanted to just kind of highlight, and we might even go back one slide. You'll find this pretty commonly in the exams that they're not going to ask you necessarily what is the diagnosis. They're going to ask you things about, say, what is the severity of the diagnosis. This is where they're starting to tease apart, we know you know what the diagnosis is. What we want to know is how well you know that diagnosis. So I can see some fantastic answers coming in here. So we've got a reduced level of consciousness. The one thing I would be avoiding there, and just good to get in the habit straight away, try and avoid using any abbreviations. Now, in the actual exam, no abbreviations are allowed pretty much at all. Again, it's doctors marking it, and so if they see the odd one here or there, there's a chance that they'll let it slide. But the official kind of stance on the RACGP is not to use any abbreviations, not even AF for atrial fibrillation, for example. So just something to try and catch yourself on. And so I know it's probably just typed in tonight, just to have an answer there. But I would encourage you to just get into that habit of spell everything out. Even MRIs, magnetic resonance imaging, seems over the top, but it's what they've said from day one. But definitely, good question. Good answer, sorry. Low oxygen saturations, fantastic. If we can, I'd try and get more specific on that. We'll talk about that in a second. Increased work of breathing, good, very good. And low blood pressure, again, I'd try and get a little bit more specific in those answers, but definitely on that right track, and you'd definitely be scoring marks there. So, some of the recommended answers here would be the acute onset confusion. I think you would have got the mark there in terms of the reduced level of consciousness. It's more about that reflection of you're acknowledging the conscious state being involved. Now, tachypnea, so the respiratory rate, and this is where I was getting at specificity. Where you can, try and specify what numbers you're classifying as high. And in this case, really, what the question's kind of teasing out is, do you know the criteria for CORB 65 or SMART COP, for example? And so here we'd be looking at respiratory rate over 25 or 30, kind of depending on which one you're really looking at. Remember, CORB is more your who needs to go to hospital. SMART COP is your who's going to need intensive support. And I think as long as you can kind of stick to one of those criteria, I think you get 4 marks there. Hypertension, again, just that specificity. Systolic blood pressure under 90 or diastolic blood pressure under 60. The tachycardia over 125, because just tachycardia on its own typically would mean over 100. And in this case, for severe illness, we'd be looking at that over 125. And oxygen saturations under 93% on room air, again, just that specificity. Increased work of breathing or accessory muscle use, technically not a part of either of those criteria, but it is one of those situations where common sense prevails, and if you've got someone that's really fighting for breath, that is definitely going to be one of those things we're going to look at clinically for hospitalisation. So very, very well done. If you want a bit more kind of reading or sources for this, ETG have a really great section on assessing severity of pneumonia or community-acquired pneumonia in adults. So feel free to have a look at that. All right, let's go to the next part of this case. So question number 2, we'll put 2 minutes on the clock. Again, if you want to throw some answers into the chat, that'd be great. And your time starts now. right, well done and good to see you again. Some really good answers coming in there. So, of course, we all know the photosensitive rash when exposed to the sun, and something you really have to warn everyone about with doxycycline. So I think we'll even go as far as, if this one's worked, gold stars for you there. Well done. Now, some other ones though. Again, this is a pretty classic question for KFP, where what they want to know is, you know the medication you would use in this setting, but can you tell me more about it? Can you tell me the side effects or the dangers of using it? Now, you're usually safe for these kinds of questions to spew forth the usual nausea, vomiting, diarrhea, which you can put for pretty much most medications. But doxycycline is as well quite well known to be irritating to the gastrointestinal tract. There is something that we haven't really talked about yet, and that is grouping of answers. And for some situations, you might be a bit nervous putting nausea, vomiting, diarrhea all as different answers. Again, just trying to keep your answers diverse, because they're all really the same thing as gastrointestinal, and they may actually all come under the same group and only be 1 mark, regardless of how many of those specific ones you put in there. Epigastric burning can be quite common with it, particularly if you're prone to ulcers or erosions. Tooth discoloration, which can occur in adults as well, but tends to be more transient in nature. We do obviously worry about the under 8 age group, where it can be a more permanent feature. Enamel dysplasia, again, while more common in children, can still happen in adults as well. Photosensitivity, and I really loved your specificity. Again, I'm going to pop it back up there as well. Photosensitive rash when exposed to the sun, absolutely fantastic. Rash as well as just general rash can occur. Stomatitis, again, being that irritation there. Fungal overgrowth as a stripping of natural flora, and photoonycholysis and nail discoloration. One of the less common, more rare things that can happen, but is worth warning patients about, as if they do get it, it can be quite distressing. You just have to wait for the nails to grow out again. They essentially just lift off from the end, and that's when exposed to sunlight. And again, comes back to that photosensitivity. All right, well done. And of course, we are now up to the third and final one for this case here. 2 minutes on the clock, and your time starts now. All right, so time is up, and so happy to see some of the fantastic responses there. Of course, absolutely nailing it there. Nature's wonders, you are a wonder. Time to first cigarette after waking, number of cigarettes per day, and symptoms of withdrawal. And that would also include symptoms of withdrawal in previous quit attempts as well. Absolutely Smashing it. Very well done. Another gold star heading your way. Now, again, this is a common trick you'll see in KFP exams where the first two questions are related and then they kind of mix it up a bit and play on some other aspect of the case history to assess a different part of your knowledge. In this case, it's part of the 5 A's. The first A is ask and knowing what are those questions you need to be asking. The next bit is assess. There we go. And so assessing the nicotine dependence to plan out your further management. Again, I would want you to be very, very, very familiar with the RACGP smoking and smoking cessation sections on their website. Very, very common questions on the KFP exam and just handy to know like the back of your hand for clinical practice as well. So very well done. All right. Now, we do have other cases, 2 whole other cases, each with 3 parts to it. So without further ado, let's get to the next case. Time starts now. Aisha's parents, I feel you. I feel you so hard. Any of you have kids? Put it down in the chat. Let me know. Man, this is a very common thing. Some kids just don't want to eat. And functional constipation is one of those things you're going to come across time and time again. Thankfully, we have lots of ways to get on top of it. And yes, definitely improving that diet is a big part of it. Getting kids to change their diet is... It's a thing. But you are 100% correct that is something that needs to be addressed, needs to be fixed up. And that is one of the biggest things they need to do. Now, of course, we have lots and lots of options, and for these kinds of paediatric questions, one of the best places to start looking for these resources is going to be the Royal Children's clinical guidelines. You'll find the college seems to pick a lot of questions based around some of their fact sheets and handouts, as well as the clinical guidelines as well. And so in particular, you'll find a lot of this dietary or bowel kind of function seems to be from there. So first thing first is to use footstools to ensure the knees are higher than the hips when toileting, or leaning forward and putting elbows on knees when toileting. Now this is where we go back to those grouping, because really what we're doing here is postural change to better align bowels for evacuation. And so technically they're 2 different things, but they are functionally achieving the same thing, and so I think it would be highly likely that they would be grouped together. A toilet ring placed over the toilet to aid. Toilet sits for 5 minutes, 3 times a day after meals. And that also just encourages part of that routine, can help take some of that kind of fear response away or distress response away as well. Stool charts or diaries. the bee's knees. Do them, they work, use gold stars, make it something that's fun and playful for the kids, and they respond really, really well to that. Anything that encourages positive behaviour, kids really thrive on. Now, encourage to exercise more. Movement is a great stimulator for bowel activity, so definitely encourage that. And is something we know as a problem, as we have an increasingly sedentary I was about to say workforce, hopefully not workforce, group of children around us. Reviewing toilet access is that they actually can't get to the toilet when they want to, so look at the barriers to using toilets. Delay toilet training attempts until a child is painlessly passing soft stools, so make it a more pleasant experience. They're not feeling like they're having to suffer pain to get the reward. And, of course, limit excessive cow milk intake. Very, very important. Now, I wanted to highlight the answer that you gave isn't technically on this list, but I would accept it. And I would, if I was marking the exam, I would probably give this a mark. And tied to this as well, this happens all the time where they get into the exam, they've made all their questions, they've made all their answers, and they see things like this. And they say, oh, wow, yeah, oh, that's actually a really good answer. And if enough people put it there, they do actually take that back and add that to the answer pool if they agree with it. And it goes through a few different committees, and this is one of the reasons why the KFP exam takes months to answer, because there's all these things going back and forth to do that. And so, yes, you've correctly identified that the diet is a big part of this, and so not only limit excessive cow milk, but definitely changing up that diet would make a massive, massive difference. All right, let's move on to the next part of the question then. 2 minutes on the clock, and your time starts now. All right, so time is up, and good to see again some answers coming in through the chat, and I can see we have a few more viewers and we have answers. That's fine. If you're not feeling comfortable putting stuff in tonight, no worries, no hassles, but work up to it, because again, we can have a look at answers and kind of tease apart ways to improve them as well. So the more you put in, the more you'll get out. Now, the one of the key things here, and I'll start off by saying, this is a question that you probably wouldn't see in a real KFP. I've intentionally kept it a little bit more vague tonight, because here it just says list 3 differential diagnoses. In the actual exam, you're more likely to see what is the probability diagnosis, what is the most likely diagnosis, what is the most serious diagnosis. Here, though, I want to just cast a bit of a wide net and get you thinking outside the box and seeing what you can come up with. And again, we have the caveat here that they have asked for serious cause of constipation, and so we probably do want to be focusing on the more potential serious causes. And so that would be things like celiac disease, hypothyroidism, which again, fantastic, well done grabbing that one. Hypercalcemia, chronic hypercalcemia can cause functional constipation as well. Slow transit constipation, so tying in a little bit to neurological disorders, but anything that's going to affect bowel motility directly. And of course then your more broad neurological disorders, or appropriate examples of which there are plenty. And so as long as you're coming up with something roughly sensible, you'd be getting that mark there. Now again, to point out, this is asked for 3 diagnoses, and this is often the case where there are many, many more. Anal fissure potentially could be causing more pain on defecation, which again would make her reluctant to actually do it. Now, the STEM does point out, as you very rightly picked up, that she avoids going to the toilet and seems distressed when attempting to have a bowel movement. And I think it's important to note the difference between distress and pain, and they are subtle differences. You could argue either way, and I think this is again one of those things where if enough people put down anal fissure, probably would get a mark, and truth be told, I'd be tempted to give a mark here, except for the fact that it does kind of hint towards more serious causes. So just something to keep in mind, but otherwise definitely good answer. All right. Let's move on to the next question then. Let's put 2 minutes on the clock. Moving on to the final question for this case, and your time starts now. All right, so boy oh boy, does the college love immunisation questions. You're guaranteed to get at least one for every single exam. And in this case, and it is often the case, you often have a couple that are kind of freebies, so to speak. So always remember, any immunisation question, influenza immunisation's probably going to be a valid answer. Now, in this case, we do have someone that's over 5 years as well, and so you would also be considering COVID-19 immunisation. And as next one you picked up again, fantastic. The infant Rix is definitely going to be due here, so it's going to be your diphtheria, tetanus, pertussis, polio. Now, the college has clarified you can use brand names, or you can specify the diseases to be covered, and they will accept those as long as it's legible. Often the brand names do get a bit confusing, and so always be mindful. If in doubt, just spell out the immunisations that you want to cover, and you're going to get those marks there. Now, it's painful. I'm sorry. You just have to learn the immunisation schedule, and that includes the immunisations for Indigenous and Torres Strait Islanders as well, and those who may be immunocompromised or at-risk populations. It's painful. It changes. So personally, I don't believe there's a point in memorising it rotely. But for the exam, it's just one of those things you got to do. Often people can kind of skimp by on putting down influenza or COVID, for example, but it is one of those things. If you do know it, it's free marks, for lack of a better way to put it, and you're guaranteed to get at least one question on, and so it probably is worth that time and effort to have. The trick I used, which worked quite well, stick it to the back of the toilet door, or stick it to somewhere that you see regularly, daily, preferably multiple times a day, depending on your bowel activities, which I'll leave to you. Have it somewhere that you're going to have that repetition and familiarity with it. Plus then, anytime you think of the immunisation schedule, you'll get the shits. Couldn't help it, sorry. Had to do it. Next question coming up. Let's put 2 minutes on the clock. And of course, this is coming into case 3, our final case for tonight. Question 1, your time starts now. All right, so great to see some answers coming through there. And the more astute of you may have noticed that halfway through the case she changed her name. Bugger. That's an editing mistake on my behalf, and I'll be fixing it up for later. I try and build cases and then go back and tweak things to make sure I'm actually trying to make it as diverse and lifelike as possible. So, whoops, missed one, sorry. Now, I did go through, and I also changed the number of differential diagnoses. I wanted to try and focus it down a little bit. I do apologise. So, a couple of mistakes tonight. Sorry, guys. Let's focus on 3, although there are many more than 3. And as correctly identified, the most likely thing here is going to be vestibular neuronitis. We've got that preceding viral illness and that constant dizziness and imbalance. So that almost classic for it, really. Of course, the other big thing that we really don't want to miss here would be cerebrovascular incident or stroke, or you could say TIA, but the fact that it's persisting would probably make me go back to the stroke kind of territory. We have Meniere's disease and vestibular migraine. So 100% correct on vestibular neuritis, and I'll point out here as well, actually just opportunistically and not to poke fun at all, but there's obviously a typo there. Don't sweat it. The college has said if there's spelling mistakes or typos or whatever, that's fine. As long as they know what you're trying to say, they don't actually care about the specific spelling, which for people like me is an absolute godsend. Now, you've fallen for my trap, my devious trap. I specifically didn't want this to include BPPV, or benign paroxysmal positional vertigo. Again, just catching you out just to try and avoid abbreviations as much as possible, because this is a constant dizziness. which pretty much instantly rules out BPPV. True BPPV is short episodic sessions of dizziness on movement, so triggered by an activity with very short bursts. It doesn't tend to actually last for long periods of time. Okay, so moving on, again, if you want to go through a really great place for differential diagnosis of vertigo, ETG actually has a really nice table and summary that I would strongly encourage you to read. There's also a couple of articles in Australian Family Physician as well that cover dizziness and vertigo, which you really have to read. This is something that is, again, not uncommon to be exam questions, but is also just one of those things that you're going to see time and time again, and is something that I think a lot of us probably could do better at and manage better if we know more exactly how to be targeting our therapies appropriately. Now, what is happening here? And we have IT troubles. When it rains, it pours, guys. Very sorry. Let's try that again. Let's bring that back up. Here we go. Perfect. It's like it never happened. You never saw anything. Let's get to the next question. 2 minutes on the clock, and your time starts now. All right, time is up. And for those who aren't familiar with the HINTS exam or haven't had to deal with this before, this exam will save you time and time again to help differentiate between central and peripheral causes of vertigo and dizziness, particularly for these cases. So we've ruled out stroke is probably one of the most important things here, and we think vestibular neuritis is the most likely diagnosis based on the symptoms that we have at hand, and so the HINTS exam essentially confirms that and excludes other central causes. That could be things like tumour or mass or change in pressure. So head impulse is moving the head to the sides very quickly, and you should see, while they're trying to look at your nose, I should mention, in particular, you're looking for saccade to the side away from the lesion. If you're seeing saccades to the side towards the lesion, you're looking at some trouble, or if you're not seeing anything at all, warning signs should go up. If we have no signs at all, hints towards central, so that's bad. You want to be investigating further. For nystagmus, that's the horizontal movements of the eye. As they look to each side, you should see that kind of beating sign towards the side of the lesion. And if you're seeing that in both directions, again, that's your sign that there's something bad going on here. You need to expand to further investigations. Now, of course, there can be a rotational element to the torsion, particularly in the case of vestibular neuronitis. That can be non-central. But if you're seeing vertical nystagmus beating vertically, you need to be considering central causes, and again, that's usually head to ED. Now, test of skew involves covering up eyes, and you'll notice as you uncover eyes, the eyes will have dropped down and then will jump back up once the eyes are uncovered. And again, there shouldn't be any skew. If you're seeing that lag and then catch up, that raise again once the cover is removed, that's hinting towards a central cause. This is something that I think, again, even just for day-to-day clinical practice, is one of those you really have to know kind of things. And again, will save your bum time and time again when you're thinking, oh boy, is this patient really, really sick? Or do they just need some therapy and rest and time and go home? Again, if you want more information on here, there is a little bit of information on ETG, but a quick Google search, you're going to find a heap of resources. And again, there's an AFP article that I would strongly recommend you read. And the Life in the Fast Lane website, if you're familiar at all with that, for emergency resources and critical care resources, have a really nice summary and a couple of videos as well that are definitely worth watching. This is one of those things, once you see it a couple of times with positive and negative examples, a lot of it makes a lot more sense. So again, I strongly recommend you check those out. All right. Moving on then to the third and final question for tonight. Thanks for sticking around this long. You probably all have better things to do at 9:20 on a Wednesday night, but love to spend it with you. Let's put 2 minutes on the clock, and your time starts now. All right, time is up, and we come to the final question. We knew there had to be something on pharmacology that's not just side effects at some point, so here we are. So again, stolen blatantly from ETG, prochlorperazine orally is first line recommended, but so is promethazine orally. And so I think you'd be pretty reasonable to prescribe either of those things, and I think you would likely see them put down as grouped as well, given they're both first line. It'd be a one or the other. I don't necessarily think you would get marks for both. The other thing that they would probably want to see there would be prednisolone orally, which has been shown to decrease the duration and severity of symptoms in some. So the evidence isn't fantastic, if I'm honest, and anyone that's had a patient with vestibular neuronitis can profess it's an absolutely horrible condition, but patients will be desperate to take anything basically to try and make their symptoms better. And there is a little bit of evidence behind prednisolone, and so it is still recommended to be given. Now, of course, for the nausea, you can also use things like ondansetron orally, but the effectiveness of things like prochlorperazine and promethazine are going to be that much higher that you would likely get more marks for putting those things and knowing those things rather than using just your more standard, we'll say, antiemetics such as ondansetron. All right. Now, probably another thing I wanted to point out here is if you do go to ETG, one of the other things you'll see for nausea without vomiting is diazepam. And you will note it is not on this list here, and intentionally, because I think there is that bit of a push to not just follow guidelines blindly, and if we can get away without using benzodiazepines, there definitely is a lot of evidence to say use everything else first, and only then I think would you be justified in trying other things there as well. And so if you've only got 2 things here, I think all of these other things would be much better therapeutic options rather than benzodiazepines. All right, so well done. You have finished your first, hopefully not last, live stream with me, and hopefully you found these questions helpful. Of course, if you did find this helpful, I really need your help. I want to try to keep doing these live streams for the 12 weeks before the KFP exam. We're, of course, 11 weeks out now, but I want to make this a regular thing. So if you found it helpful, fantastic. Come again. If you know other people that might help as well, feel free to spread the word. And, of course, I'll be catching you guys at next week's live stream with 3 more questions and some more hints, tips and tricks. Of course, I always leave a little bit of time at the end here, so if you've got any questions, feel free to throw it in the chat. If you had questions about, say, the questions we asked tonight, general questions about the KFP, or questions about myself, I've got a bit of time to answer them. And, of course, if there's just anything else you would like to know, here is your opportunity. Pardon me for coughing. I managed to at least get the microphone muted. Now, of course, I'm also keen to find out more about you guys and find out what I can do to tailor this towards what you need as well. So if there's particular areas, feel free to email me. Put it up here. My name is Kane Treble, and my email, surprisingly enough, is just kane.treble@gmail.com. Email me. Ask questions away. You can comment on the videos as well. And again, I would love to help you in any way I can. There is that course that's on the way. At this stage, it's probably going to be another couple of weeks before I've got anything really in place. And it's going to be in a similar kind of format to these live streams where I talk through things, go through some example questions, and you can just kind of step through at your own pace and basically learn all the tips and tricks that I really wish I had have known before I sat my first exam, and certainly the things that I did to get me through my last exam. All right. Not seeing any questions coming through, which is, again, perfectly fine. So, again, thank you guys very much for joining me tonight. Absolutely thrilled to have you here. If you found it helpful, feel free to subscribe, spread the word, and I will see you guys 8:30 next Wednesday for the next KFP session. Thank you, and have a great night.